Good morning to everybody. So welcome to the EUROTOX webinar. So today we are very pleased to welcome the Professor Martin Wilks from the University of Basel. So Martin obtained a doctorate in medicine in 1986, and then a PhD in toxicology at the University of Surrey in England. So he's an MD PhD. He has spent nearly 20 years in senior position as a medical toxicologist in the National Health Service and chemical industry in the UK and Switzerland. And then he became director of the Swiss Center for Applied Human Toxicology in 2009. He's also an adjunct professor of toxicology in the Department of Pharmaceutical Sciences at the University of Basel. He's, of course, an European registered toxicologist. He's the past president of the European Association of Poison Center and Clinical Toxicologists. He's the current Secretary General of EUROTOX and the president-elect of EUROTOX, which, as you know, is here. It's not European Society, it's what we call the World Society of Toxicology. So his research and professional interests include clinical toxicology, toxicoepidemiology, and risk assessment of chemical exposure. So Martin today is going to give us a talk with the title is Poison Control Center and their role in toxicology and public health. So it's a very interesting presentation because we will have an insight of what is clinical toxicology and the role of Poison Center. Please put your question in the chat. Don't ask questions during the presentation because we have a little bit about 10 minutes of question at the end of the presentation, 10 to 15 minutes. And so please put your question in the chat. And then if we have no more question in the chat, then you can ask your question directly by oral. And the presentation is recorded. Okay, thank you very much. Martin.
Thank you very much, Mark, for this kind introduction. Let me share my presentation with you. So I've now put it on presentation mode. Can you see that okay?
Yes.
Very good. So first of all, a warm welcome also from my side to all participants. I recognize a few names of friends and colleagues there, so it's great to have you here. The presentation I was asked to give today is around poison control centers. How they are being set up, how they're being used in toxicology and public health. And I'm going to do this, but just by way of formal disclosure, Mark has already mentioned that I'm a former president of the European Association of Poison Centers and Clinical Toxicologists, but have no other interests to declare. So this is what I had in mind for the presentation today. I will start with a brief introduction on the global scale of poisoning, and then go into more detail of what a poison center actually is and what it does, including some of the guidelines that are available for poison centers. And one of the things I've also been asked to do was to try and illustrate the kind of help that poison centers can give. And we've chosen as an example the opioid crisis, primarily in the United States, but also elsewhere. And then I conclude with a summary, and at the end of the presentation, I will show some select resources about poison centers and chemical incidents that you may wish to look at in your own time. So, the global scale of poisoning, these are data that are perhaps not the most recent ones, but they're the most recent ones I was able to find, primarily sources WHO, but also an article in the literature. The estimate is that there are around 100,000 deaths from unintentional poisonings per year. And of course, with that associated also a large number of injuries and an estimated loss of over 6 million disability-adjusted life years. if you're looking at the scale of the problem, it's very unevenly distributed around the world. For example, there's an estimated 80 to 140,000 deaths from snakebite per year. And these are, of course, disproportionately associated with developing countries. And also, there are over 100 suicides with pesticides per year, once again, primarily in developing countries. Sorry, that wasn't meant to do that. Here we are. As you can see in that picture from the right-hand side, which is showing a hospital ward in Sri Lanka with a patient that has come in with organophosphate pesticide poisoning. Very often these kinds of incidents happen in resource-poor locations, and doctors, nurses, and other healthcare workers are struggling to treat these patients appropriately. So there is a global issue on poisoning, and poison centers are one of the ways in which we can try to address this. So what is a poison center? The general functions of a poison center are around provision of poison information services, but sometimes there are clinical toxicology and or laboratory services associated with this, and I will touch on these in the subsequent slides. So the provision of advice to healthcare professionals and the general public is the primary role of a poison center. And around the world, there are different models. Some of the centers only provide advice to healthcare professionals. Others also include the general public. But generally, they are staffed by specialists in poison information who tend to be pharmacists, physicians, nurses, who have received a special training in the provision of advice in poisoning situations. Nowadays, it's still by and large done by the telephone. However, web-based technologies are increasingly used around the world. And some countries have also developed online resources that people can access without the need to directly call a poison center. Here is an example from one of these online resources, and that is from the United Kingdom National Poison Information Service. It's called ToxBase. Now, the UK NPIS is one of those services who only provide advice to healthcare professionals. So you have to register and then log in with your username and password, and you can then access the information on specific poisons. If you're a member of the general public, you have to go through one of the other resources that the National Health Service has before you can get this kind of advice. Here are some data on the use of the ToxBase online service, and this is from the latest report that is available from the NPIS. And as you can see, the ToxBase use started round about 2000 and has steadily grown to around 800,000 to 900,000 accesses per year. And as you can also see, let me just try and get a pointer. As you can also see on the telephone inquiries, up until the end of the 90s, and this was a time when I was working in the London Poison Centre, and when we had over 100,000 telephone inquiries per year, this has gone down significantly over the years and is now a stable around about 50 to 60,000 calls per year to the Poison Centre. The consultant service has also increased over time. This is then when cases cannot be handled directly by the user through ToxBase or through the telephone, then a specialist consultant is being involved. So online services are becoming increasingly important for poison centers. Now, when you collect the data on poisoning incidents, or when you're being called or have an online system, there's a huge amount of data that is becoming available. And the analysis of such data is one of the other functions of a poison center, also quite often termed toxicovigilance. And this is analyzing the inquiries that you receive with the aim to identify, for example, the circumstances of poisoning, the substances involved, the populations at risk, and a whole host of other data that could be useful. Because these data then enable public health services to perhaps better target their interventions on the basis of real data that are being collected, and also regulatory measures to try and prevent poisoning incidents can be introduced more easily if the data are available on which to base those measures. Here's another example of those types of data, and I've now chosen to use the example from the United States, the National Poison Data System. Now, a reason why I'm not using a European example is that, unfortunately, even to this date, we don't have a European-wide collection of data to a similar standard. And that is in contrast to the United States, where all of the country's 55 poison centers feed in their information in real time to the NPDS. And therefore, this is a huge resource in now over 70 million case records and several hundreds of thousands of products that are being involved. And this system can then be queried not only by regulators or by public health officials, but also, for example, companies who wish to obtain data on their own products can query this kind of system. And if you go onto their website of the US poison centers, you can find the NPDS interactive dashboard. And that is a free resource. You can, for example, click on this by your state, or you can look at some of the hot topics. And here I've just circled the fentanyl exposures. I will come back to that in the case study. And this is updated on a regular basis. And it's a useful resource, not only for public health officials, but for a whole host of other interested stakeholders. So this is the poison information side. However, there are potentially other aspects of a poisons unit or poisons center that are important. One of these is a clinical toxicology unit. Now, not all, or perhaps only a minority of poison centers have a specialist treatment facility. Some hospitals have, for example, special beds in an intensive care unit that are staffed by nurses and physicians who have a specialist training in medical toxicology. And as I mentioned, it may or may not be associated with a poison center. There are some clinical toxicology units that are treatment facilities without providing poisons advice, and the other way around. But these treatment units also have an important role in understanding the effects of toxic substances, kinetics and mechanisms, because they directly treat the patients, they can collect the data and can monitor the outcome of the patients. And last but not least, they are also a unique training opportunity for poison information specialists. The third element that may be associated with a poison center is the laboratory service. And this is a service that allows the analysis for toxic substances and other biomedical investigations. Of course, in a hospital setting, you want to have a rapid diagnosis which supports the clinical management. I have to say, however, that by and large, with very few exceptions, the laboratory analysis or the identification of the toxic substance is usually not possible in time to treat a severely ill patient. So physicians have to work on the clinical picture and the patient's history and then very often the laboratory service is there for confirmation, but not necessarily to target the treatment approach. However, laboratory services also support public health decision-making. For example, they may be able to analyze chemical substances in a chemical incident or other industrial accidents and so on. And therefore, their service is often combined with other public health services, such as forensic medicine, or also in companies, occupational toxicology, therapeutic drug monitoring, or veterinary toxicology. Poison information centers have been around now for more than 50 years. The first ones were established in the late 1950s, early 1960s. And of course, their role has evolved over the years. But there's a huge amount of information available from those centers, and that can be used and has been used to establish sort of internationally accepted guidelines what a poison information center should do, how it should be set up, and the kind of things that are important. And one of the early guidelines, international guidelines here, is from the World Health Organization's International Program of Chemical Safety that published these guidelines in 1997. Of course, guidelines need to be updated, and it's been not too long ago that a new version of these guidelines was published by the WHO. It's freely available on the WHO website, so you can look at it if you're interested. The reason, of course, is that science changes, but also the way we can use information sources has dramatically changed over the past 20 years, and that needed to be taken account of. So some of the new or extensively revised chapters concern the role of poison centers in the management of chemical incidents and chemical emergencies. Others involve, of course, there's a large chapter on toxicological information sources, which has been extensively updated, taking account of databases such as PubChem, or the kind of databases that I mentioned when I showed the example of ToxBase. There are a number of those available in other countries as well. There are general toxicology resources via the World Health Organization, the International Agency on Research on Cancer, OECD, and other organizations, and a huge array of books, journals, bibliographic databases such as Medline, PubMed, or ToxLine. One important chapter also that has been updated is around the training of poison center staff and the area of quality assurance. Training of poisons information staff and medical toxicologists is not internationally standardized, so many countries have their own way of dealing with this, but there are a number of basic aspects to this, the areas of training that need to be covered, and the assessment of the success of the training. One important aspect that has become more prominent in recent years also is the quality assurance. So providing advice using standard operating procedures, the professional development and appraisal of staff, auditing and checking of calls, and very importantly also user satisfaction surveys that are now increasingly being used by information centers. Now, you may have noticed that the title of this manual has changed now to Guidelines for Establishing a Poison Center. One reason for that is that still to this date, less than half of the countries around the world actually have formal poison information centers. And one of the reasons for that is very often a lack of funding. And this is something that when you talk to poison centers, regardless of the country that you're in, every poison center will tell you that they're struggling to get sufficient funding for their activities. And of course, you could say that funding is, should be provided in adequate form by the government, by health agencies and departments, but in practice, that is not always the case. And so it's sometimes the institution that runs the poison center that provides funding, but increasingly also other sources are needed for that. For example, insurance providers or poison centers have to look how they can supplement their income, for example, by charging for some of the advice or some of the services they do, not only to government agencies, but also to commercial entities. A principle of poison centers virtually everywhere is that the individual user of the center, so the person who calls the center, should not be charged for receiving this advice. Nevertheless, the funding to provide the service needs to come from somewhere. So these guidelines also providing information on this aspect. Now, I would like to move on to our case study, and we've chosen as the case study the opioid crisis starting in the United States in the mid-1990s. You may have read some of the literature. There are 2 books I would recommend. Getting some interference from somewhere, so if you could please make sure that your microphone is muted, that would be great, thanks. So you may have seen these 2 books, Dopesick and Empire of Pain, and they both characterize the origins of the opioid crisis in the United States, starting with prescription drugs. And if you're in the younger generation, not so much inclined to read books, there are 2 series that you can stream. Dopesick was the first one to came up. There's also a Netflix series called Painkiller, which pretty much are based on these books that are available. So what are we actually talking about here? The opioid crisis started in the mid to late 1990s in the United States, when the use or misuse of prescription opioid painkillers triggered the crisis. This in the early years did not receive much public attention. However, in the early 2000s, the number of deaths from overdoses began to surge in the United States, now primarily related to heroin, but also other drugs of abuse were involved with that. And in 2014, 2015, deaths from fentanyl, which is actually an opioid that has been used in intensive care medicine for decades, but became available on the street market. And in 2016, there was another switch when cocaine deaths also became more prominent. And up to the 2020s, those death rates from more than one substance continued to increase. And here's basically the trend in the United States from the late 1990s until very recently. And what you can see is that there's been an exponential increase of drug-involved deaths over that just over 20-year period. And the death toll from drug overdoses now stands as over 100,000 per year in the United States. 2/3 approximately male, 1/3 of these are females. And when you chart where these deaths occur, there is also a development that you can see over the years. So here is the area circled, that's West Virginia and the Appalachians, where the prescription opioid crisis initially started. However, even at that time in the late 90s, there are other areas in the United States that already had a fairly high incidence of drug-induced deaths that you can see here on the color chart. And as you go along with the years, these areas are gradually expanding. And when you then look at this up to around about 2015, this is when then the fentanyl death started. But you now see that large areas of the country have incidences over 20 per 100,000 of the population per year. So it is no longer a crisis that is confined to a number of small areas in the United States. It is indeed a national crisis. The substances that are causing most of these drug deaths are synthetic opioids. And you can see that there is this spike of deaths here from synthetic opioids from 2014 onwards. And that is when fentanyl first appeared on the street markets. In the early 2000s, it was still pretty much the synthetic, prescription opioids that dominated those deaths. And these in the public mind are still nowadays associated with the problem. However, as you can see, it's these other drugs, in particular, the synthetic opioids, the fentanyls, that are responsible now for the large majority of deaths. So how did that happen? You have two populations, if you like. One is people who are suffering from pain, sometimes chronic pain, and those certainly in the 1990s, with help from irresponsible industries as well, were prescribed opioids to a much larger extent and for much longer times than previously associated. And if you prescribe opioids for a long period of time to people, you get addiction. And if then those opioids no longer become available, people switch. So the people in pain also eventually start to switch to other drugs. And here's where for example, the illicit fentanyl is coming in. The other population is the recreational abuser who may be using different opioids at the time. This person now also may get access to fentanyls and other of the street drugs. And here's where overdose and death is becoming much more of an issue than it was previously. What has been the response of the public health authorities? Well, one of the responses, and that's a classic response of many state authorities, is to try and limit the supply. Now, if you're dealing with prescription drugs, there are certain measures you can take. For example, you can try to limit opioid prescriptions or start prescription drug monitoring programs in individual states. You can take some action against manufacturers, as has been done. You can have better monitoring and laws for pain clinics, and you can also try and increase the measures of law enforcement, drug seizures, and so on. However, that is only part of the issue, because you also need to intervene on the demand side. And programs for opioid replacement therapy were instituted or were enhanced in that time. You can try and improve the access to inpatient and outpatient treatment facilities, and you can try some new approaches. In recent years, for example, the use of psychedelic substances in drug abusers has been advocated and is being monitored in clinical trials. We don't have time in the lecture today to go into that. And you can try and reduce the harm in those people who are actually using the drugs. For example, the accessibility of naloxone, which is the antidote to opioid overdoses, that can be given to users and others to manage overdose situations much more readily. Clean needle programs, safe injection programs, and so on. And of course, a large proportion of these users have significant mental health issues. So the enhancement of mental health treatment facilities there is of importance. So how have these measures been successful? Well, it depends what you describe by success. Clearly, the number of deaths from prescription overdoses, prescription opioid overdoses has gone down. Certainly in terms of the ones that are used without any other opioids. So you can see that from the mid-2000s onwards, there's a steady decline of those deaths. However, at the same time, the number of deaths that have used these drugs, including other synthetic opioids, has increased. So the overall number here has plateaued. And one of the reasons for that is, I've already alluded to this, that users switch to other opioids. So if the prescription opioids are no longer available, there's a much higher chance of users switching to illicit drugs. And this has been studied, for example, in prescription drug monitoring programs, where mortality has actually been increasing even after these interventions have been carried out, because users have been switching to illicit drugs from prescription drugs. So it's not just, a single answer to reduce the availability of prescription drugs. And what you can also see is that other drugs have come in there. I mentioned cocaine in there, and the number of deaths that also involve cocaine has exponentially increased also from the mid-2000s onwards. Again, very often in combination with synthetic opioids. So the individual or only cocaine users without any other opioid has only increased a small amount. So it's these combinations that are really causing the problem. Other drugs, benzodiazepines. Now, we don't normally associate benzodiazepines with drug deaths. They are really quite safe in many instances in overdose. However, the reason why these deaths have increased where benzodiazepines have been mentioned is once again because they are being used in combination with synthetic opioids. Less so for antidepressant. The overall number of antidepressant-related deaths has increased substantially, but not as dramatically as that with opioids. And here you can see that they are not to the same extent being used in combination with opioids. On the other hand, heroin-involved deaths have been falling. The heroin without any other opioid deaths have been substantially falling here since around about 2015, and where you had this increase in association with other opioids, this is also now coming down. So, points to note on this one, and I should have mentioned this at the outset, but these slides on the United States situation were given to me by a friend and colleague, Rick Dart from the Rocky Mountain Poison Center, who gave a very good presentation on this at the recent EAPCCT Congress in Munich last month. So his conclusion is it's not an opioid crisis, it's a drug crisis, where the synthetic opioids kill most people, but they are not the root cause of the problem. And we've heard this very often. The problem is not the drug, it's the behavior of using the drug. And therefore, simply trying to get rid of certain drugs is not going to be the answer. So we can't just harm reduce our way of this. We must address the root cause. And that, of course, begs the question, what is the root cause? I'll leave it here because, we don't have time to discuss the details of this, but clearly it's a multifaceted problem. So what about the European situation? Well, We have in Portugal, in Lisbon, the European Monitoring Center for Drugs and Drug Addiction, EMCDDA, and they publish an annual European drug report. And the most recent one has just been published. And I've got a few data from this report to show you what the situation currently is in Europe. So the other thing to mention is that the EMCDDA will now become the European Union Drugs Agency, the EUDA, as of the beginning of July. And this is not just a name change. They will have their resources and also their mandate increased quite substantially because the European Union has recognized that the drug situation is also a problem for Europe. It's not just elsewhere. And when you look at the trends in drug-induced deaths in European Union, including here data from Norway and Turkey, what you see is nowhere near a dramatic picture as in the United States. There's more a slow increase over the years. This is from 2010 onwards. There's the odd spike in certain countries, but generally it's a gradual increase rather than a dramatic increase as we've seen in the United States. Now, these data need to be looked at in caution because the European Union is not a heterogeneous continent. It's comprised of different countries, and those different countries have different ways of collecting data. In some countries, only police data are included. Some countries only confirmed deaths, and so on. So the data from one country to another is not strictly comparable. So it's likely that the overall number of drug-related deaths is considerably higher. Nevertheless, it is clearly not as high and dramatic as it is in the United States. However, also here, opioids, including heroin and its metabolites, and very often in combination with other substances, are involved in about 3/4 of the fatal overdoses reported in the European Union. So the numbers may be lower, but the substances that are being used are not dissimilar to what we're seeing in the United States. In Europe, heroin remains the most commonly used illicit drug and is responsible for a large share of the health burden attributed to illicit drug consumption. However, the opioid problem is evolving in ways that are complex and that require maybe different ways of addressing it. And just as an example here, the age distribution of people entering treatment with entering drug addiction treatment with heroin as their primary drug. What you can see between 2010 and 2022, there is an age shift. So the population using heroin has grown old, if you like, with using the drug. The peak age is now in the mid-40s, where it used to be in the mid-20s 10 or 15 years ago. So not only the kind of drugs that are being used are shifting, but also the population is changing, and public health officials need to take that into account. So we're coming to the end of my presentation, and I would like just to summarize the points that were made throughout the presentation here. So I hope I've been able to show you that poison centers are indeed a vital part of a country's public health service. Their main role is provision of specialist advice, and this can be in different places to different groups of people, certainly healthcare professions, very often also the general public, but government is also one of the target audience of provision of this advice. One of the very important functions of centers is the data collection, toxicovigilance, which allows monitoring of trends, both existing and emerging trends in drug use, drug misuse, overdose deaths, and so on. And these data certainly contribute to a better management of these kinds of public health threats, as we are seeing currently with the opioid crisis. And the opioid crisis clearly is a multifaceted societal problem that requires coordinated responses by many different stakeholders. So it's not a one-size-fits-all approach by any means. I mentioned some selected resources. This presentation is being recorded, so you can look at those in your own time later on, such as the guidelines for establishing poison centers. There's additional WHO guidelines that are available. And here the last point I mentioned is radars. This is in the United States, in Denver, Colorado. They are collecting some of the surveillance data that I've shown you in the US situation. And I'd like to acknowledge here Rick Dart, who is the director of the Rocky Mountain Poison and Drug Safety Center, and also an executive director of the radar system, and who has kindly provided me with the slides for the US situation. And with that, Mark, I'd like to finish and like to thank everybody for their attention. And I'm, of course, very happy to answer any questions. Thank you.
Thank you very much, Martin, for this very informative presentation with a great example on the opioid crisis and the role of Poison Center. So I have questions in the chat. So I have two questions from Gad. So the first question is, thank you very much for this great presentation, Professor Wilks. Here is my question. When adverse events or poisoning occur, what are the investigation pitfalls that you would face, what you have faced or seen?
Well, hello, Gad. Good to see you, and thanks for your mail earlier, and congratulations to the birth of your grandchild, by the way. Yeah, what are the pitfalls? I think the difficulty is very often in the early stages of a poisoning incident when you're not really sure about the substance that is involved, because rarely are we in a situation where you have a specific toxidrome that you can clearly link to a substance. I mean, our classic example is if you have a poisoning with organophosphate insecticides, there is a clear toxidrome associated with it, and doctors can recognize this quite early. But in many poisoning situations, the patient comes in and you don't really know. You have a muddled history. There are other potential causes, medical causes that can mimic also poisoning situations. So I think the first point is stabilize the patient. Whether the patient is poisoned or not, you need to stabilize that patient and then worry about the poison. And also perhaps to say that there are rarely specific antidotes. I mentioned the opioids, and of course there are specific antidotes. But in many of the other pharmaceutical poisonings, you don't have a specific antidote to treat the patient with. So I think it's training of and seeing many cases that is avoiding those pitfalls.
So there is a second question. Is MEDRA still the chosen method of adverse event classification in clinical toxicology?
We very often use the poison severity score. This was developed in the 1990s by a collaboration of the International Program of Chemical Safety and the European Poison Center associated. Of course, when you have a patient in a clinical situation, you have things like, the Glasgow Coma Scale and Apache and other general clinical assessment systems. But for poisoning situations, the poison severity score is the one of choice that we're using.
And there's a question for another attendees. Could you please elaborate more on the qualification required to secure a position in the Poison Control Center, specifically clinical toxicology, is a subspecialty of internal medicine. You mentioned that the staff might include nurses, pharmacists, doctors, etc. That's a
Yeah, it's a very good question and one that is very difficult to answer because the situation is different in every country, not only worldwide, honestly, but also even in Europe. Some countries have a specialization in medical toxicology. For example, in the United States, there is a board certification in medical toxicology and a training program associated with this. In most European countries, this is not the case. So somebody would go through a general medical, usually internal medicine or emergency medicine, and then specialize in poison information. Some countries are beginning to recognize this as a qualification, but there's a long way to go. So most people I know that have gone into clinical toxicology have done so because they were in places that recognize this as an important area rather than entering a specialist program. And as for the poison information specialists, indeed, this is also done differently in different countries. So in most countries, they are using, as I mentioned, pharmacists, nurses, sometimes physicians, who have undergone a special training. The training is usually done in the facility itself. So increasingly, national societies are now providing guidance for specialist training for poison information specialists. But this is not really terribly well established. So I'm afraid I cannot give a very good answer to your question, other than if you find a place that you like, you're very likely have a good chance because they're always on the lookout for good stuff.
Just to complete your answer, in France, for example, concerning the laboratory, so there is toxicology laboratory in the hospital, and so you have to be a pharmacist trained in biology and in pharmacology, toxicology to sign the results, to give back the results to the MDs. So if you're not a pharmacist, you cannot give back the results from the laboratory.
Indeed. So it depends on the country that you're in, and but there are usually societies in the country that are helpful in providing some advice.
So there is an additional question from linked to the case study. So it is linked to the case study. Are deaths mainly linked to respiratory depression or other organ failure?
Very often respiratory depression. I mean, that's the key factor in opioid poisoning. And don't forget, many of these deaths occur outside a healthcare facility. This is a particular problem with fentanyl because this is such a powerful opioid, 50 times stronger than heroin. And you never know what kind of purity you get. Now you have very potent, very pure substances on the market, and people just very often overdose without even realizing it because they're using a new batch which is much stronger. Respiratory depression is the main factor, and this is also why, for example, the naloxone, which is the immediate antidote, should be part of every emergency response, so that it can be given, even by emergency responders who may not be medically qualified, because it's an easy drug to give, and very often you have to do that prior to people entering hospital. Multi-organ failure you see very often when you have complications, and also quite often with other drugs, not necessarily so much with the opioids.
A question for Emanuela. So I have a curiosity. Besides opioids, there are new emerging class of poison.
Oh, that's a whole, hello, Emanuela. that's a whole different lecture, actually. Yes, there are, and they're constantly changing and evolving. We tend to term them novel psychoactive substances. And these are, if you like, chemical variants of established things like amphetamines, ecstasy, and those kinds of drugs. And honestly, there are dozens, if not hundreds, of those coming on the market every year. And quite often we have to play catch up because, you know, people would claim they are legal substances. You can buy them on the internet. You know, they just may have a tweak in their chemical structure. It's a huge issue. And if you come to our Poison Center congresses, always the novel psychoactive substances it's a standing item because every year new substances come on the market. Also, actually, in the opioid area, there's a new class of substances called the nitazines, which have emerged in the United Kingdom very recently. Again, variants of opioids, which are very, very strong, almost in the fentanyl area. So it's, yeah, as I said, it's a topic for another lecture, which we may want to do at some stage in the future. But yes, it's forever changing. It's never a stable situation.
I have a comment from a colleague from Colombia. So it's one of the difficult issues that we have is the needs for some antidotes and specific treatment that is not always available at the site where the patient is. We have difficulties to have those antidotes. Here in Colombia, I'm building a strong system that guarantees the delivery and the proper use of the antidotes we have. Just to mention, for example, we don't have fomepizole and hydroxycobalamin, which I understand is quite an issue. So it's a common, but maybe Martin, you can have a general comment on the antidotes and the availability.
Yeah, good point. I mean, I said that at the outset that many poisons don't have specific antidote, but there are, of course, some who do. And the ones that I mentioned here, fomepizole is used to treat toxic alcohol poisoning, methanol and ethylene glycol, hydroxycobalamin in the treatment of carbon monoxide exposure. I mean, fomepizole is the point in case. And you know, he makes a very good point. It's not a cheap drug. It's and to actually have it in stock requires considerable resources. So many countries are struggling with this, and not only developing countries but also countries across Europe. Very often the solution is that you have to have sort of more centralized levels of antidote stocking. But some of the more the newer and more expensive antidotes are simply not be available. It's there is an essential antidote list from the WHO, and I don't think there is a simple answer to your problem. I recognize it, and it's been discussed, for example, when we had the Congress of Toxicology in Developing Countries in April in Chile. This was mentioned also on a regional basis, for example, whether countries or physicians in countries could get together on a regional basis. But then always you have the problem, do you get the antidote to the patient at the right time? So it's very difficult, and I'm afraid I don't really have a good answer to your question, except that I recognize the problem.
So there is no more question in the chat, but I have one question just before the end. So I understand there is the creation of a European Union Drugs Agency, okay, which is not EMA, okay. And so do you know if this, one of the tasks or the mission of this agency will be to try to homogenize or normalize the practices all over Europe? Because I understood that it can be very different from France to England to Hungary to Austria in terms of organization, type of diploma you need to be a good to run a poison center, etc., etc.
Yeah, it's a good question, and I think we'll have to see how it evolves. I mean, clearly, it's been upgraded, if you like. It now then has the status of a European Union agency, so that is more high profile than it was before. I certainly know that they have then more resources to to help with the data collection, the monitoring, and the epidemiology. Whether they will also be able to, influence practice in certain countries, I'm less sure. I think, like with many European agencies, they're only as good as the member states let them, and especially in an area where it comes to practice. I would not hold my hopes too high that they can significantly influence that. However, I believe even if they only, in inverted commas, manage to actually collect more harmonized data across Europe, I think that even would be a major step, so that we maybe have monitoring situations so that the situation in Estonia is comparable to that in Austria or Italy to Germany. And I very much hope that that will be one of the focus areas of their activity in the future.
Yeah, because
it's a start. It's a good start.
It's a good start, but as you just mentioned during the presentation,
Yeah.
I mean, in US, it is a drug crisis, not an opioid crisis. And it will come one day or another in Europe, as we see with synthetic drugs that are more and more used by young people.
Yeah.
Okay, so there's no more question. So if there is no more question, no, someone want to ask a question? So we are at the end of the time anyway. So again, thank you very much, Martin, for this very interesting presentation, very informative, very complete. And you had a lot of questions, actually. People were very, very interested, and it was very well attended.
Good. Yes, it was fun. And thank you for the audience and also for asking those questions, which were all very good and many not easy to answer.
Okay, thank you again, Martin.
Thank you.
So bye-bye to the attendees.
Bye.